When a person visits the doctor's office for a routine health screening or due to an illness or injury, a certain number of standard procedures are performed before the physician even asks the purpose of that person's visit. These standard procedures often include anthropometric readings such as height and weight, resting heart rate, oftentimes exercising heart rate, and blood pressure. The purpose of this presentation is to look in more detail at blood pressure and the device used most commonly in assessing blood pressure, the sphygmomanometer. Arterial blood pressure is considered one of the human body's vital signs in that major abnormalities indicate serious health concerns. Although low blood pressure or hypotension is a condition that can lead to major problems, healthcare professionals are more frequently on the lookout for high blood pressure in the general population. A person with hypertension, high blood pressure, is at a greater risk of developing cardiovascular, cerebrovascular, renovascular, and other vascular diseases. When arterial blood pressure is measured, two pressures are taken. These are the systolic pressure and the diastolic pressure. The systolic pressure refers to pressure in an artery as blood is pumped out the heart during ventricular contraction, or systole, and the diastolic pressure refers to the pressure in an artery during ventricular relaxation, or diastole. Although aortic pressure is the most accurate means of assessing arterial blood pressure, the brachial artery is measured due to its greater practicality. The brachial artery is close to the aorta and also at the same level on the transverse plane, which is important due to the way gravity affects blood pressure in different regions of the body. Blood pressure is given as a systolic over diastolic number in millimeters of mercury. Normal pressures are in the range of anything close below 120 over 80 millimeters of mercury. Hypertension is scaled in levels of severity starting at stage 1, where systolic pressure is 140 to 159 millimeters of mercury, and or diastolic blood pressure is 90 to 99 millimeters of mercury. What we can extrapolate from any blood pressure reading is pulse pressure and mean arterial pressure. Both of these values reflect cardiovascular health. Mean arterial pressure, for example, determines the rate of blood flow through the systemic circuit. A number of factors can influence the increase in arterial blood pressure, including increases in blood volume, heart rate, stroke volume, blood viscosity, and peripheral resistance. Poor diet, such as high cholesterol, and inadequate exercise can amplify these factors and assist in the development of hypertension. From the original discovery of blood pressure by Stephen Hales in 1733 to modern advancements in the measure, the great importance of blood pressure to clinical diagnosis has remained constant. As it is used today, the sphygmomanometer is comprised of three parts: the occluding cuff, the manometer, and the stethoscope. The cuff consists of an expandable rubber bladder contained in a non-dispensable cuff. Attached to this cuff is an inflation bulb, which contains a valve in order for the tester to release or contain pressure in the cuff. The stethoscope, consisting of a head, tubing, and earpieces, is placed over the occluded artery to maximally amplify the Korotkov sounds. The auscultatory method of determining flow is pivotal to accurate blood pressure reading, and that is why practitioners use a stethoscope. The stethoscope is used so the observer can hear the blood gradually pumping its way back through the artery. There are 5 phases in the Korotkov auscultatory method. Phase 1 refers to the first appearance of clear, repetitive tapping sounds. This coincides most accurately with systolic pressure. Phase 2 sounds are softer and longer, whereas Phase 3 sounds become crisper and louder. At Phase 4, the sounds become muffled and less distinct, and Phase 5 marks the time where no more sounds are heard. This, although debated, coincides most accurately with diastolic pressure. In order for correct blood pressure measurements to be performed, the subject must be in a resting, seated position with good posture and feet on the ground. The arm being tested must not be elevated, as isometric contractions will result in false readings. Instead, the arm must be comfortably rested on the surface so that the midpoint of the upper arm is at the level of the heart, or the fourth intercostal space. The subject should not have sleeves rolled up, as this may result in a slight unwanted occlusion of blood vessels. The observer should perform the test in a quiet, calm environment so as not to be distracted and so all Korotkov sounds are heard clearly. The observer should have a pen and paper nearby to record data and both hands available so one can hold the inflation bulb and the other can hold the stethoscope. If an aneroid manometer is used, it is often attached to the cuff in view of the observer. After the cuff is wrapped around the subject's arm, the observer should squeeze the bulb to increase pressure in the bladder. A useful method in predicting the systolic pressure is to observe through palpation of the radial artery the approximate pressure where flow is occluded. Once pressure begins to fall again, the return to flow should be around that pressure. The American Heart Association instructs observers to inflate the cuff rapidly to about 70 millimeters of mercury, then increase by 10 millimeters of mercury while performing the above palpatory method until flow has definitely stopped. The observer should then place the stethoscope on the brachial artery so that it is not too firm to interfere with blood flow and not in contact with the cuff to cause audible interference. The cuff, once inflated approximately 30 millimeters of mercury above predicted systolic pressure, should then be opened at a rate of 2 millimeters of mercury per second. At this stage, the observer must listen out for the first Korotkov sound and note the accompanying pressure as the systolic pressure. The diastolic pressure occurs at stage 5, where silence commences, although many argue that stage 4 is the more appropriate reading. Stage 5 is defined as the moment sounds end, however, so this is the most accurate reading of diastolic pressure. Blood pressure is an ever-changing element of a human's physiological makeup, and so one reading, therefore, must not be considered a subject's definitive blood pressure. Multiple tests spread throughout the day and averaged will give a more appropriate diagnosis of cardiovascular health with regards to blood pressure. Faulty devices are always an issue when using medical equipment, and the device should be maintained and stored correctly. This is especially important for the aneroid manometer, which requires frequent calibration. Throughout history, the study of blood pressure from its earliest roots has involved some of the most highly regarded scientists in medical science history. From the discovery of blood pressure by Stephen Hales to the refinement of non-invasive techniques by Korotkov, the importance of accurately reading this physiological measure has never been lost and will always be a necessary starting point in any medical diagnosis.